Hey everyone, welcome back to our Masterclass Explainer. If you were with us for the last session, you know we spent a ton of time untangling the wild world of surgical modifiers. Well, today, we're officially leaving the modifier realm behind and jumping right into the trenches of procedural coding for breast care. We're going to focus specifically on percutaneous fluid management and minor surgical interventions. Look, whether you've been coding for years or you're gearing up for your CIRCC exam, nailing these foundational procedures is absolutely critical for getting clean claims out the door. So let's get into it.
Okay, here's our game plan for today. We're going to start with percutaneous cyst aspiration, then move into deep abscess drainage, or mastectomy. After that, we'll tackle the hematoma evacuation trap, run through some clinical coding case scenarios, and wrap it all up with our key takeaways. Section 1, Percutaneous Cyst Aspiration, navigating CPT at 19,000 and the add-on code 19,001. All right, we're kicking things off with our primary code here, 19,000. This code is all about the percutaneous puncture and evacuation of that initial cyst. Now, the absolute keyword to remember here is percutaneous, literally meaning through the skin. The provider is just taking a needle, inserting it directly into that fluid-filled sac, and draining it. There's no big incision, no opening things up for exploration. It's just a highly targeted, needle-based evacuation. Code 19,000 is basically your foundational building block for this procedure. But keep in mind, it only covers the very first cyst the physician tackles.
But what happens when there's more than one? Well, that brings us to the add-on rules, which really show how we build out the rest of this claim. You're going to use plus 1901 for each additional cyst. So, say your provider aspirates 3 cysts total. You'd report 1900 once and then 1901 twice. It's just a strict counting game at that point. Oh, and another huge thing, always remember to unbundle and separately report your imaging guidance. Never just assume it's somehow baked into that primary code, because it's not. If they use ultrasound to guide the needle, you could 76942. If it's MR guidance, you grab 77021. Just double check that the radiological supervision and interpretation are actually documented in the operative report before you slap those imaging codes on there.
Section 2, Deep Abscess Drainage, also known as a mastotomy. Exploring CPT 19020. Now, we really need to anchor these procedures by comparing them. When a provider does an incision and drainage, you absolutely must distinguish between a superficial skin IND, which gets coded as 1060 or 1061, and a deep parenchymal exploration, which is a mastectomy, CPT 19020. Think about the anatomy for a second. The breast has lobes, ducts, and that subcutaneous adipose tissue. When we talk about a mastectomy, we mean the provider is going deep. They're going past those superficial skin layers, right into the actual breast tissue to explore something suspicious or to drain a deep abscess. So depth is your main determining factor here. Because of that depth, a true mastotomy, again, CPT 1920, follows a very specific surgical pathway. Step 1, they make a surgical incision right over the site. Step 2, they thoroughly irrigate that abscess fluid. But step 3 is what you're really hunting for in the operative note. The wound is usually packed loosely with gauze. Why do they do that? To promote free drainage. If they were to stitch it up tight while an infection is still brewing in there, that fluid would literally have nowhere to go. Now, here's a quick coding caveat for you. What if the surgeon goes deep, explores the tissue, but doesn't actually find an abscess? Well, in that case, they will go ahead and close the wound with sutures, but guess what? That deep exploration itself still qualifies for the 19020 code. Moving right along to Section 3, the hematoma evacuation trap, coding post-operative complications. Okay, listen up, because this is absolutely crucial. If you're auditing or coding the evacuation of a post-operative hematoma and a reconstructed breast, there is a massive pitfall you need to dodge. First off, a hematoma is just a localized collection of blood outside the blood vessels, right? And it's a pretty common complication after a major surgery like a mastectomy and reconstruction. Now, the knee-jerk reaction for most coders is to instantly grab the integumentary breast codes. I mean, the procedure is happening on the breast, so why wouldn't you? Well, that is exactly where the trap springs. Here's the deal. Reconstructive flaps are unique. They often use skin, fat, and muscle that's been relocated from a totally different part of the body to form that breast shape. Because of this, you actually need to report CPT 21501. That's an incision and drainage code meant specifically for the soft tissues of the neck or thorax. You do not use your standard integumentary breast codes for deep hematoma evacuations in this specific reconstructive scenario. The tissue being drained is, for coding purposes, acting as thoracic soft tissue, making 21501 your only accurate choice. Seriously, burn this one into your memory.
It is a classic trick question on coding certification exams and a huge target for claim denials.
Section 4. Clinical Coding Case Scenarios. Let's test your knowledge.
Time to put on your coding detective hats for case 1. Imagine you're looking at a chart, and the documentation says the provider performed a percutaneous aspiration. They treated exactly 3 separate cysts. Oh, and they performed the whole thing using direct ultrasound guidance. So how exactly are we reporting this combo of services? Take a quick second to mentally build your code stack. You got it?
All right, let's see how you did. You'd start by reporting 19,000 for that very first initial cyst. Next, you need 2 units of our handy add-on code 19,001 to cover cyst number 2 and 3. And finally, since imaging is never, ever bundled into these specific codes, you've got to report 76,942 to capture that ultrasound guidance. If you nailed all 3 of those components, fantastic job. You are clearly on top of your add-on and unbundling rules. Okay, let's look at case 2. You're reading an operative note and it says, quote, "Deep incision and drainage of a breast abscess. The wound is irrigated and packed loosely with gauze. I want you to pay really close attention to the depth of the procedure indicated here and that very specific packing technique they describe at the end. Based on that, what single CPT code are we looking for?"
Did you say 190220? Because if you did, you hit the nail right on the head. This scenario is a textbook match for CPT 19020, which confirms a deep mastotomy rather than just a quick superficial drainage. The magic words in that operative note that steer you totally clear of those superficial 10,060 codes are deep and the fact that it was packed loosely with gauze. Those are your glowing neon clinical indicators that the surgeon was working deep down inside the breast parenchyma. And that brings us to Section 5, Key Takeaways. Time for our wrap-up. Let's do a quick recap. First up, remember that 19,000 is strictly for percutaneous needle punctures, and you've got to remember to unbundle your imaging for those cyst aspirations. Second, always verify the parenchymal depth in your operative note. That's how you confidently choose a deep mastotomy over a superficial skin drainage. And third, watch out for that reconstructive hematoma trap. When a patient has a deep collection in a reconstructed breast flap, you have to leave the breast codes behind and grab that thorax code, 21501. Next time around, we're going to tackle a really fascinating area of breast surgery, localization devices. I mean, if imaging guidance codes can trip you up during a simple cyst aspiration, just think about how you handle them when wires and clips are being placed at the exact same time. It's a whole puzzle, and you definitely won't want to miss how those combine. Thank you for watching, keep coding with confidence, and make sure to subscribe to Decode Healthcare with Harshal. See you in Part 4.